So we had an amazing session here at BTOG 25. We were really in a very multidisciplinary meeting here, and in an amazing session, again multidisciplinary, discussing how we manage our patients with stage 2-3 operable lung cancer. We heard from surgeons, radiologists, radiotherapists, medical oncologists. We had several amazing presentations. We had some really good discussions about patient selection. Should we be using preoperative chemoimmunotherapy for our patients? I think in stage 3 this is very well established. There's a debate as to whether we should be using these in PD-L1 negative patients. The current data, I think, would suggest that these patients still do derive a benefit, and we're lucky in England that we can use chemoimmunotherapy in patients that are PD-L1 negative. There's a bigger question for our stage 2 patients as to whether we should be using chemoimmunotherapy. And there may be a debate for our PD-L1 negative patients in this setting, perhaps even our node negative PD-L1 negative patients. They may benefit from going straight to surgery, but it remains a matter of debate. And we had considerable debate as to whether these patients should be having primary surgery or preoperative chemoimmunotherapy. What is very clear is that we are pushing the envelope for who would derive benefit from surgery. And the question really is, in our stage 3 group of patients, who are those patients that are borderline resectable, borderline unresectable, and who do we select for a neoadjuvant strategy, and who should go directly to a Pacific approach of chemoradiotherapy with consolidation durvalumab. What is very, very clear is that focusing on R0 resection is absolutely critical. We need to ensure that when we select our patients, not only is the case operable for the patient-related factors, but also is resectable with technical factors to ensure that our patients receive an R0 resection. So true multidisciplinary input to our patient selection is really quite critical.